call upon Dr. Soumya now. She would be talking about SafeWay retrospective study to compare the results of PRK in high and low myopic patients. Dr. Soumya.
So no financial interest. So PRK is a surface photoablation technique in which the anterior corneal stroma is reshaped to correct the hemetropia by irradiating with argon fluoride excimer laser following epithelial debridement. More residual stromal bed remnant than LASIK reduces the risk of post-operative ectasia and the need for any enhancement procedures, which are the main benefits of PRK over LASIK. So in those cases that are unsuitable for LASIK, PRK offers to be an excellent alternative. The aim of the study is to evaluate the 24-month visual outcome of PRK in patients with low to moderate myopia as compared with high myopia. The primary outcome of the study was to document the postoperative UCVA, secondary outcomes being postoperative MRSE, efficacy, safety, predictability, stability, corneal haze, among other complications. So all those patients who presented to us between May 2020 to 2022 were recruited in the study who satisfied the inclusion and exclusion criteria and were divided into 3 subgroups, basically depending upon the refractive power as low, moderate, and high myopia respectively, and they were made to undergo the pre-operative evaluation protocol. And the 6th generation MRS excimer laser version 500E squint iTech solution using OrCam software was used to do the procedure. 6.5 mm was taken as the average optical zone following excimer laser ablation. The stromal bed was soaked with 0.02 mmC of varied duration, 10 seconds being for each diopter, and then it was immediately irrigated with 30 ml of chilled BSS solution following BCL application. So post-operative regimen included uses of topical antibiotic and lubricants on an hourly basis, along with prednisolone eye drops for the first 3 days till BCL removal. Following the BCL removal, antibiotic drops were tapered down to 4 times and were completely stopped after 1 week. Lubricants were continued for 6 months. So in cases of low to moderate myopes, we have resubstituted prednisolone eye drops with loteprednol eye drops, which were tapered down from 4 times to on a monthly basis for 4 months. And in high myopes, we have continued the prednisolone drops itself on a monthly tapering basis for 4 months. So this modified steroid regimen helped us to decrease the post-operative haze in most of the patients. So in those cases that were steroid responders, prednisolone drops were resubstituted with loteprednol or cyclosporine drops respectively, as IOP monitoring was done at every visit for all the patients. So coming to results, Fisher extract test and Crucible Wallis test was applied as normality was not satisfied. The median ablation depth was 85 to 90 microns for high myopes, 40 to 60 for moderate, and 30 to 40 for low myopes respectively. So BCVA at the end of 12 months was almost the same across all the myopic refractive error groups, which indicating that it was not statistically significant. Only one patient in the high myopic group had BCVA of 6/12 in the right eye and 6/18 in the left eye due to persistent grade 2 corneal haze. This is because the patient was non-compliant to medications and follow-ups. The efficacy index was calculated as ratio of mean postoperative UDVA to mean preoperative CDVA, which was around 1 across all myopic refractive error groups, indicating that it was statistically significant. The postoperative MRSE across all the myopic refractive error groups was in a minimal range, indicating a good predictability value, as we can see in this linear regression line. And the safety index was calculated as ratio of mean post-op CDVA to mean preoperative CDVA, which was around 1 across all myopic refractive error groups, indicating that it was statistically significant. So as we can see, postoperative BCVA was unchanged across all myopic refractive error groups and was not statistically significant at the end of 12 months. Gain of 1 line and loss of 1 Snellen line was seen in few cases of high and low moderate myopes respectively. The safety and efficacy indices were excellent across all myopic refractive error groups, indicating a good predictability value and stability value. So a modified postoperative steroid regimen and use of PRK adjunct with MMC application, range being minimum application of at least 30 seconds for 1 diopter to 50 to 60 seconds for 6 diopters or more, helped us to reduce the immediate postoperative corneal haze in most of the patients. Few patients in the high myopic and moderate myopic group did have dry eye symptoms and night vision problems like glare and halos, but these were transient and improved over time. To conclude, our research shows that PRK is a safe, predictable, stable, and successful treatment with fewer complications for high myopia with results comparable to low and moderate myopes. Regression incidence and postoperative complications are minimal due to enhanced treatment profile, expanded optic zone, and transition from broadbeam to flying spot and use of wavefront optimized software. Limitations of the study being that record and follow-up of long-term outcomes such as efficacy, stability, and complications of PRK in high myopic refractive cases is also needed. So these are my references, and thank you.
You said less than -6, more than -6. What was the maximum you went?
Madam, we have subdivided into 3 groups. 6 diopters or more were classified as high myopes. 3 to
More means how much more?
till ma'am, MRSC we have taken as till -9 diopters, spherical and cylindrical together. So 6 to 9 most basically, and not more than -9. 3 to 6 was classified as moderate, and less than 3 as low myopes for us.
What is the corneal thickness across the groups? Especially in the
Average was
higher-
around 520, ma'am. Minimum being from 500 to 504, and maximum being till 565 to 570 respectively.
Is the refractive error correction the main aim, or did you have a grading system on the haze also? Because we didn't see any slide on the PRK
Grading
haze.
system on the haze actually was subjective only because like I didn't I do agree that I didn't keep this slide for the same, but we did grade it with Fante scale of grading, which was grade 0 for no haze, grade 0.5 for mild haze, and grade 1 when there is a significant haze but not obscuring the iris details and not interfering with the visual acuity, and then grade 2 for your moderate obscuration of iris details, grade 3 and
So, good you know that,
Yeah.
but there are enough
Yeah, we did,
publications on
yes.
PRK, high
Yes.
myopia, so and so forth. So this paper, if you want to make it more impressive the next time, because the results of PRK the publications are there in thousands and thousands of that. So probably if you're doing a comprehensive study on PRK results, then haze becomes a very important factor, because that's the only drawback which holds people to do PRK in high myopia.
Okay,
So how you dealing with PRK? What was the result? Because efficacy wise, we all know PRK is a great procedure, and all the higher generation machines are all flying spots and
Yes,
so and so forth. So 2 things you need to add in your paper. One is the haze criteria,
Yes,
and have
ma'am.
few clinical pictures if possible,
Yes, ma'am.
document that. And secondly is epithelial mapping. So
Okay,
that
ma'am.
also needs another slides and some comparative there, because that's a new thing. We are not doing PRK without epithelial mapping now. So if you
Okay.
get access to anterior segment OCT, so that will just make your paper much more comprehensive and better, so that you can present it in more international forums and other things.
Okay.
Good work.
Thank you so much.